To invite Dr. Anand Vinekar, who's going to talk to us on white, yellow, and red in a baby's retina. What should I do?
Thank you, Anand, and thank you, Saurav, for this opportunity. It's amazing to see a full audience during lunchtime. Keeping in theme with the colored images and disease entities that you've seen, I'm going to talk about babies now. And many of y'all may not see babies in routine, but as you know, they're not going to be very cooperative. And we sometimes get just a few seconds, maybe less than a minute. So the idea of this presentation is not to get us to the diagnosis, but just to look at these lesions and suspect what we might be looking at. And that's really enough. These are actually very common conditions. While we were doing ROP screening, we published this paper which showed that almost 7 to 8% of babies can actually have other retinal conditions. And they can vary from retinoblastomas, which you've picked up quite incidentally even in a 1 or 2, 3-week-old baby, with infective lesions, some of which we'll see. And then when we extended this from preterm babies to term babies, again, we found that there is a common occurrence of, and the most common occurrences that you find are actually retinal conditions and not anterior segment. As much as you'd like to think that congenital cataracts and corneal problems are common, they're not. In fact, retinal diseases and entities are far more common in babies. And this is what we found in that study of universal screening. In the first 3 days of the babies being imaged, we found including retinoblastoma and salt and pepper retinopathy, as you can see in one of them, and referred these babies to the cardiologist. So optic nerve head lesions, you saw the first speaker talk about this. So this is a very classic morning glory syndrome. The diagnosis is as important as the fact that there might be any CNS anomalies, and we must refer to the neurologist. This is an optic nerve atrophy or sometimes aplasia, again, often associated with corpus callosum absence or miswiring in the brain, and becomes our duty to refer for the same. Bilateral disc edema and pale disc edema is something that we might miss, and these are all RETCAM images. All these images, almost of all the babies I'm showing you, are less than 2 to 3 months. So it's often difficult to make the diagnosis if you're not knowing what to look for. So here, the condition was an intracranial pressure secondary to a mass lesion and then a hemorrhage as well. This is sometimes almost passed off as normal. When you see crowding of the blood vessels nasally, one must think of trisomies, and it's very classically described in Down syndrome, but can also be seen in the others. So less colored, I think, is very obvious what we're talking about. So it's albinism. This is such an easy diagnosis to make, but as they grow older, it's important to understand that about 30% of them will have foveal hypoplasia, and they might or might not have nystagmus. If you have the facility to do an OCT in a child and they have the preserved ellipsoid zone, then they can improve to up to 6/12 with amblyopia therapy. If they don't have the ellipsoid zone, which is the photoreceptor layer, then the nystagmus may become a bigger problem. But not all foveal hypoplasias must be accompanied with albinism. As you can see here, there's no albinism, but there is foveal hypoplasia. And in them, one must suspect genetic abnormalities, especially with the renal systems. Now, when we're looking at white lesions, train your eye to this lesion here along the inferior arcade. When you look at this lesion, always look for skin lesions. In this case, this was a tuberous sclerosis, and what we're looking at maybe sometimes an retinal astrocytoma and sometimes a combined hematoma. Also, don't get excited too much when you find one lesion. Sometimes the other lesions in the fellow eye are much more subtle and can be missed out. We've published this paper where there are different appearances of these hematoma lesions. Some of them light up on angiogram and the others don't, and that depends on how smooth the contour is. If it's an irregular contour, it will flash up, and if it is not smoothened out, usually there's no leakage of dye. Of course, this is a cherry red spot. So often the pathology is not the spot itself, but the pallid edema, a pallid retina just around it. One must again refer these babies to a neonatologist. This pale white lesion now is still going on white. This white lesion was actually seen in a little slightly older child, a 2-year-old child who had nephrotic syndrome, and this is a procoagulative disease. And this child had a combined retinal artery and a vein occlusion, went from PL vision to 6/12. And if you go back to the image, it's because of the partial sparing of the cilioretinal artery distribution. And this was because it was picked up so early, low molecular weight heparin, and of course reversal of the nephrotic syndrome was done, and the child regained very, very useful vision. But sometimes these white lesions are more innocuous. They might look small, like here, they might look around the vessels, and you might tend to miss it. And a lot has been said about retinitis and retinochoroiditis in the previous talks. So it can happen in children as well. It can happen in infants as well. And in this case, we found that what was looking like a very innocuous case of small segment of retinal vasculitis was actually a large fungal abscess sitting on both kidneys and secreting candida in the urine. This has a very high morbidity, very high mortality. Fortunately, because of a clinical suspicion, the child was treated with intravenous amphotericin on time, and the child made it alive with very good sequelae. So what you sometimes see in the retina can actually save the life of a child, let alone the vision. Going now to yellow lesions, it's obvious that the yellow lesions will be exudates. You saw a lot by Dr. Vishali Gupta there. Now these, when you see them in the posterior pole, always look at the periphery, and not all of them will have the telangiectasias. So I know we are thinking of Coates disease, and also remember that Coates doesn't always happen in male. There are sufficient female children who will have Coates, and sometimes Coates can also be bilateral. But when you see bilateral Coates, one must rule out familial exudative vitreoretinopathy. At least in southern India, from Karnataka at least, the consanguinity is extremely high, and we see this very commonly. So when you look at exudations in the center and in the periphery, and this is a female baby, it can still be Coates. Now, quiescent Coates is a big mimic. The exudation is all gone, but the telangiectasias have broken off. Sometimes they are treated, sometimes it's spontaneous. But what you're left behind is with some amount of cicatricial changes. And if you look carefully, you will see the localized dilated nodes here, and that's what helps you make the diagnosis. Red lesions, it's very obvious we're talking about blood. Now, retinal hemorrhages are the most common causes, or most common findings in a baby. And probably you already know that normal vaginal delivery is 12 times higher chances of having retinal hemorrhages than C-sections. And that's because of the more controlled outlet that happens in a C-section. This is not to propagate C-sections, but it's important to ask for the mode of delivery when you're looking at these conditions. This has got a classification called EGGI's, E-double-G-E, EGGI's classification grade 1, 2, and 3, and it is the third grade that can be amblyogenic. So if it is a very large hemorrhage in the macula, more than 1.5 to 2 disc diameters, and in the center, then maybe one needs to follow. But when you have white-centered hemorrhages like these, then obviously you know, classically we've learned in postgraduate entrance exams that it's subacute endocarditis. Well, that's the least common condition. The most common condition is actually anemia, and then sepsis, and then necrotizing enterocolitis. And these are the more common conditions that we see, at least in our country. Yes, endocarditis is one of them, but that's really not that common, but it's good to suspect that as well. When you look at intracranial bleed, any instrumental delivery, was forceps used, was it a difficult passage of labor? These are all important. And when you get a yes on that, please try to examine the retinal periphery. As you can see here, this is classically called dehemoglobinized blood. And this means that there was blood, sometimes at multiple planes, like a Terson syndrome, preretinal, intraretinal, subretinal. And when they go away, they leave that pigment. And that's a hallmark that you might be able to pick up even if there's no blood. These choroidal lesions, sometimes they are smooth, and then you can think of them as a vascular lesion, and this could be a choroidal hemangioma. But sometimes, especially when they are lumpy, they're irregular, they're unequal, they're non-symmetric, and if you're seeing it in a sick child, this really is like a metastasis. And this could be a metastasis of cancer. This could be one of infection as well. So one must rule out a systemic condition and work with a neonatologist. Now, again, like you saw that white lesion and you looked at the skin of the child, here's another condition. When you look at peripheral neovascularization, think of incontinentia pigmenta, right? It's an X-linked dominant condition. It's not as uncommon as we think. And only if you see this child in the acute phase will you see the hyperpigmentation. After some time, it just goes away and you can't make out that there was a skin lesion. But this, you can really preserve the retinal function. If you diagnose the peripheral neovascularization, like we have seen here, if you do laser timely, these babies will not detach, and often otherwise they go bad. Racemose, as we've seen in the previous talk, are almost always associated with CNS abnormalities. Again, becomes an important important to refer to the pediatrician. Now, all colors put together. So we did white, yellow, red, and now what if there are many? Now, most commonly when you look multiple colors, you'll see a little bit of black, which is basically RP, hypertrophy. You see a little bit of yellow, which is exudation. You see red, which tells you it's an acute problem. And then you see white, which is either sclerosis. You're either dealing with a dystrophy or a uveitic condition. So it's fairly simple now. So again, logic will tell you that dystrophy is usually symmetrical and may be associated with visual problems, but not so if you're looking at a pre-verbal child, as I'm trying to show you here. Or if you see these asymmetric lesions in the periphery, then you might actually be dealing with uveitic conditions, and especially if it is asymmetric. MPPC, these are all, again, fairly rare syndromes, and the full form is there, and that's often associated with CNS abnormalities. And never be happy with just a normal looking posterior pole. Yes, it is easy to see children in the posterior pole, but if you can look at their periphery and you see old subretinal changes, you're actually picking up quiescent uveitis, which sometimes might need a workup because you don't want a recurrence. And the fellow eye of the same baby that I just showed you in the periphery is this. So now this tells you this is burnt out uveitis. So burnt out uveitis, if you picked up just a few weeks back, it would probably look like this: full-blown occlusive retinal vasculitis. I'm just going to end with a few of the more common conditions that we expect children to have: a falciform fold, which is very classical of familial exudative vitreoretinopathy. And again, as the name itself says, there has to be exudation, there has to be vitreopathy, but doesn't have to have both together, but look for them. And then this, of course, the most common condition we deal with in our country, retinopathy of prematurity. And nowadays we have aggressive ROP. There's a whole instruction course on that, so I'll skip. To summarize, how whenever you look at a baby, get a quick view of the posterior pole, take a systemic history, try to see the periphery, and there are instruments that help you look at the periphery even if it's not imaging, correlate whether this is an acute or a chronic condition, and decide now, even if you're not the specialist to handle it, is this something that you can follow, or do you need to refer? And by refer, I mean to a pediatrician or a systemic specialist. And finally, a multidisciplinary approach is most appropriate. Document all the time. Don't jump to a diagnosis. That way you will block your mind off. Always describe what you're seeing, because in a baby, these signs will change. Thank you.